Please be sure as you join to use the chat function throughout the meeting. But now, as you're joining, let us know your organizational affiliation and title, if you would, so we can see who's present in the meeting. So we'll go ahead and begin recording now, please. My name's Lucy Savitz, and I'm a professor in the Department of Health Policy and Management at the University of Pittsburgh School of Public Health. I'm also a senior advisor for the UPMC Health Plan Center for High Value Healthcare. And joined with me today is Dr. Lisa Simpson. Dr. Simpson is the CEO and president of AcademyHealth. And we're going to be really sort of facilitating this meeting as we move through the agenda. We've partnered with AHRQ and the Scientific Resource Center to bring awareness to and help disseminate research findings of the ongoing evidence reports published by the EPC program. Today, the reports we're highlighting focus on a new research in pain management. We will be have opportunities throughout the discussion for Q&A, but again, please feel free to raise your hands and use the chat function as questions arise, and we'll be sure to get to them in the discussion portion of the meeting. So on the next slide, you'll see a brief disclosure. Neither Lisa nor I have any conflicts of interest, nor do our speakers to report at this time. At the conclusion of the webinar, we hope those in attendance will have gained insight into the learning objectives listed on this next slide. And at that time, you can we'll drop a link into the chat so that you can take the evaluation survey for those wanting to earn continuing medical education. So please feel free to use the chat function as we go through, because we really like these meetings to be highly interactive. So we've already done sort of the welcome and sort of business pieces of what we're doing. We're going to go ahead and start the introduction next of the EPC report authors, who are going to be sharing what they've learned with you. We'll then do an introduction of the discussants and move through the agenda as we have an opportunity to ask questions, not just the questions that we've received in advance, but questions from you to help extend the usefulness of these particular reports and think about ways in which we can do that. And then we'll have some closing remarks at the end of the meeting. So without further ado, I would like to introduce Dr. Sushi Iyer, who's the Director of Technology Assessments Program for AHRQ's EPC division. She's unable to present for us in the meeting directly today, but she's generously agreed to record an introduction of our report authors who've made time in their busy schedules to join us. So, Sushi.
Everyone, welcome to this afternoon's Grand Rounds. I'm Suchitra Iyer. I direct the Technology Assessment Program within the Evidence-Based Practice Center here at AHRQ, and we'll be introducing the speakers for this afternoon. Well, pain affects millions of adults in the United States and is the leading cause of disability, and also pain significantly impacts physical and mental functioning and quality of life. And acute pain, if not treated adequately, can progress to chronic pain. AHRQ's Evidence-Based Practice Center program has been committed to the promotion of evidence-based approaches to safe and appropriate treatments for pain. And so in partnership with our sister HHS agencies like NIH, CMS, and CDC, we have a robust portfolio of systematic reviews that address various aspects of pain management. But this afternoon, we will feature 3 reports. One on non-invasive, non-pharmacologic treatments for chronic pain. The second on cannabis and other plant-based treatments for chronic pain. And the third on acute treatments for episodic migraine. It's with great pleasure that I introduce the speakers. Dr. Raja Chou is a professor in the departments of medicine, medical informatics, and clinical epidemiology, and a staff physician in the internal medicine clinic at Oregon Health and Sciences University. He has served as director of the Pacific Northwest Evidence-Based Practice Center that is housed at OHSU, and has conducted and led systematic reviews related to pain management. Many of his reviews have been used to develop clinical practice guidelines by the American College of Physicians, the U.S. Preventive Services Task Force, the American Pain Society, and the CDC, to name a few. He has served as the director of the American Pain Society's Clinical Practice Guidelines Program and a grade methodologist for several WHO guidelines. And he's also on the member of the board for various medical journals. Our second speaker, Dr. Hassan Murad, is professor of medicine at the Mayo Clinic College of Medicine and Sciences. He leads the Mayo Clinic Evidence-Based Practice Center program and also holds appointments in Knowledge and Evaluation Research Unit, Center for Science of Health and Care Delivery, and the Division of Preventive, Occupational, and Aerospace Medicine, as well as the Division of Healthcare Policy and Research. Dr. Murad is a member of the GRADE Working Group and serves as a panelist and methodologist for multiple professional societies and organizations. He also serves as peer reviewer, editor, and board member for many medical journals. And with that, I turn it over to the speakers.
Great. Thank you, Sushi. I really appreciate it. And thank you, authors, for joining us today again. And thanks to those of you who are using the chat like we asked. We appreciate that. Next, I'm going to turn it over to Dr. Simpson, who's going to introduce our discussants for today's meeting. Lisa.
Thank you, Lucy. Wow, a really impressive lineup of speakers, and that is complemented by an equally impressive lineup of our three guests and discussants, Dr. Bernard Costello, Nicole Hemingway, and Dr. Monica Wang. Now, Dr. Bernard Costello is the Chief of Pediatric Maxillofacial Surgery, Associate Vice Chancellor of Health Science Integration, and Professor of Oral and Maxillofacial Surgery at the University of Pittsburgh Medical Center. Nicole Hemingway is the Chief Executive Officer of the U.S. Pain Foundation, a nonprofit organization dedicated to serving those who live with conditions that cause chronic pain, as well as their caregivers and care providers. Our third respondent is Monica Wang, who is an Associate Professor of Community Health Sciences at the Boston University School of Public Health and Adjunct Associate Professor of Health Policy and Management at Harvard. Thank you so much to our discussants for joining us today, and look forward to hearing your comments after the presentations. With that, I invite Roger to begin the presentation of his reports.
Oh, great. Thanks for having me, and I'm glad to be here. And first, before I start, just want to acknowledge my teams that helped. Couldn't have done these reports without them. These were both complex and reviews, and the cannabis review is ongoing. I also wanted to preface this by saying that these are large reviews, and we have limited time, so this is an overview. There's more details in the reports, of course, that are both available on the AHRQ website, and happy to answer questions if people have them. Next slide, please. The first review I'll be talking about is our review on non-invasive, non-pharmacologic treatments for chronic pain. Just brief background, chronic pain is often defined as pain lasting more than 3 months or persisting past normal tissue healing time. The distinction between chronic pain and acute pain is important because once people have pain that persists for longer than 3 months, their trajectory of improvement is much worse than in people who have acute pain, where the trajectory is typically for rapid, marked improvement in the first days to weeks. Chronic pain is a leading cause of disability. It impacts physical and mental functioning, productivity, quality of life, and relationships. In some analyses, chronic pain has the most global impact in terms of disability and impact on people. Chronic pain is also a challenge because it's often difficult to treat. It's associated with high direct costs related to treatments, as well as indirect costs related to inability to work or decreased productivity while at work. And chronic pain is complex and multifaceted. There's many types of conditions that can cause chronic pain. that have a different underlying biology. And there's also important psychosocial contributors to chronic pain. So we know that these can impact how people are able to manage and experience their pain. In some cases, psychosocial factors can reinforce or worsen pain. Many non-pharmacologic treatments are available for chronic pain, so that further makes this complicated for both clinicians and patients, as well as policymakers. In 2016, the CDC guideline, which really focused on opioids, but did address use of non-opioid treatments and basically said that non-opioid treatments are preferred for chronic pain. 2018 AHRQ review that our center did found that some non-pharmacologic treatments for chronic pain were associated with sustained, defined as more than 1 month following the end of treatment, but small benefits, and small means on average less than a point on a 0 to 10 point pain scale. This review that I'm going to be talking about today was commissioned in 2019, and it was commissioned to support an updated CDC guideline. Next slide. There's some challenges in evaluating non-pharmacological interventions for chronic pain. As I mentioned, there's many chronic pain conditions, and there's questions about whether you can apply, whether if something is effective for, say, low back pain, whether it's also going to be effective for, say, osteoarthritis or fibromyalgia or other types of pains. There are also many non-pharmacological interventions. The non-pharm interventions are also complex in terms of they vary in terms of methods. So, for example, there's many different types of exercise, there's different types of massage or manipulation or acupuncture techniques, etc. The duration of these therapies can vary, the frequency, i.e. how many times per week or per month they're given, the intensity of the treatments. It's not like giving a drug where it's a pill that somebody takes. These are dependent on the skill of whoever's administering. So lots of factors here that make this different from, say, looking at a drug. There's also variability in and selection of the comparators. So there's lots of different comparators, such as no treatment, usual care, wait list, minimal intervention, other treatments. And it can be quite difficult to mask some of these non-pharmacological interventions. It's very difficult, if you're giving psychological treatment as the intervention for people not to know that they're receiving psychological treatment. Same with exercise and many of these other interventions. There are some cases where researchers can produce clever sham treatments or close to sham treatments or use things like attention controls, but this does make it more complicated. It's some of the effects are, likely to be related to, knowledge of the treatments being received and placebo and other effects, non-specific effects. There's also variability in the timing of outcome assessments, from, during treatment to, months or years after the end of therapy. We don't think the short-term outcomes are as important given the chronicity of long-term pain. So of chronic pain. So we focused on long-term outcomes in this report or sustained benefits. But the evidence on long-term outcomes is quite limited. It's also tricky to define the magnitude of benefits. Almost all interventions for chronic pain have effects that are below what are often proposed minimum clinically important differences, which are often around 1.5 points on a 0 to 10 point pain scale. As I mentioned, many of the treatments, the effects are less than a point or around 1 point. We chose not to just use a single MCID threshold because we do think patients may value benefits that are smaller, and there's other factors that can influence decisions to use treatments associated with relatively small benefits. We have limited evidence on outcomes other than pain and function. The trials tend to evaluate pretty selected populations, so they tend to enroll people who don't have a lot of, say, psychological issues, who aren't using, say, opioids, etc. And another challenge for this report is just how to present this vast array of evidence. Next slide. This shows the analytic framework. It looks kind of busy, but it's a relatively simple framework. It just shows that, it just lists the interventions that we're talking about. So that just illustrates that there's a variety of different types of interventions we'll be looking at. The population, we focused on a few specific chronic pain conditions that account for, the majority of chronic pain. Some of the factors that we think may influence how people respond to different treatments. The key question 1 to 5 arrow is just looking at benefits of the various therapies. We always look at harm, so that's the arrow coming down, and then the various outcomes. Most of the data are going to be on function and pain, though we did try to look at other outcomes. And then, as I said, we focused on studies that assess treatment outcomes at least a month after completing treatment or 6 months after starting treatment. And then we categorize by duration of follow-up, short, intermediate, or long-term. And next slide. This is how we categorize the magnitude of effects. I'll just focus on the pain here. So essentially, if something was 5 to 10 points on a 0 to 100 point pain scale, or 0.5 to 1 point on a 0 to 10 point NRS or equivalent scale, we consider that to be a slight or small magnitude of effect. So not commenting on whether it's meaningful or not, just saying it's small. A moderate effect is 1 to 2 points or equivalent, and large is over 2 points. We use similar cutoffs for function, and then in some cases we had to convert to SMDs, and those are just standard thresholds there. Next slide. As I said, there's a lot of evidence, so I tried to summarize. We focused on a couple of pain conditions. I think chronic low back pain. Just for this presentation, just because there's more evidence for this condition than for some of the others. We tried to, summarize the evidence in tables like this that are, color-coded. So you'll see that, and using symbols, so that you'll see the plus signs indicate the strength of evidence. So 1 plus sign means that it's low strength of evidence or low certainty. 2 pluses is moderate certainty or strength of evidence. And then you'll see that the colors, so when it's colored yellow, that basically means we found no effect. The grayed out ones mean no evidence, and then the ones that have colors, the greenish colors, mean that we found some effect. It says slight, but that's a synonym that we used for small. And then describing the magnitude of an effect. And you'll see that the things that kind of pop out here is that exercise looks to have moderate effects at intermediate and long term. So these are sustained benefits. So 1 to 6 months after completing therapy or more. Mind-body practices like yoga, we also found some evidence of moderate effects. Otherwise, primarily slight effects, so less than 1 point on a 10-point pain scale, as I mentioned. The other thing I think to just point out here is that there's less evidence of effects on function, though some data, for example, for psychological therapies with sustained effects at intermediate and long term. Multidisciplinary rehab is a combined intensive rehabilitation intervention, so that's listed at the bottom, and you'll see that that's also associated with some benefits there. Next slide. And then this is additional, so the prior slide focused on what we call active interventions. So these are things that engage in terms of movement or activity or psychological, cognitive behavioral kind of approaches. Whereas these are what we call more passive approaches, where something is being done, to the patient primarily. So, receiving ultrasound or low-level laser, getting massage, traction, etc. And I think what the take-home point here, I think, is that you have more grayed out areas, so there's more evidence gaps here. You don't really have, the only area where we get to moderate benefits for pain is for low-level laser. None of the other interventions get to that. And then you have a number of these yellow boxes, which indicate that, there's no clear effect or no benefit. So less evidence to support, again, what we refer to as more passive interventions, though some of them are associated with, again, slight or small benefits. Next slide. This is just to briefly summarize some of the data we have on different types of interventions versus exercise. So we weren't just interested in comparing interventions against, wait list or nothing. We also wanted to see what how they compared against other active interventions. To make this manageable, we tried to focus on what we thought were, kind of standard comparators. So, there's literally, dozens or maybe even hundreds of potential head-to-head comparisons, which would make a report very difficult to read, especially if you have a lot of comparisons with one or two trials. So we focused on what we think were key comparisons, and this is primarily against exercise. So you'll see that we do have some data that compare these interventions against exercise. I think the main take home from this is that, if you compare the mind-body practices versus exercise, there's not much difference. In a couple of cases, the evidence slightly favored exercise. Multidisciplinary rehab did have some slight benefits over exercise, which makes sense because it's a much more intensive type of therapy. And then again, you'll see with these passive therapies, there's not much evidence that they're better than exercise, with a couple of potential exceptions. So those green boxes there. Next slide. I just briefly, I'm not intending to go over these forest plots in detail, but just to show that, we ran meta-analyses. These are what the estimates of effects are based on. So you'll see this is exercise versus usual care, attention control, or placebo. We also ran many stratified and subgroup analyses, which didn't change our conclusions very much. But you'll see the mean difference is minus 1.27. That's on a 10-point pain scale. So that's that meets our threshold for a moderate effect. And then the strength of evidence is based on, the precision of the estimate, how good we think those studies are, the consistency, which is the I-square, etc. And you'll see that we stratify by the duration of follow-up. So there's a lot of these plots in the report is where we generated a lot of the results. Next slide. And then you'll see this is the result for function, where we have a moderate effect at short term, right? So this is a standardized mean difference, I believe, but no effect at intermediate or long term. Next slide. So in summary, the findings from this update were largely consistent with the 2018 AHRQ report. Again, that a number of non-pharmacological therapies are associated with some sustained benefits. They're not large, but some people may respond better than others. We're talking about average benefits here. Exercise, multidisciplinary rehab, acupuncture, CBT or cognitive behavioral therapy, mind-body practices. This includes things like yoga, mindfulness-based stress reduction, Tai Chi, Qigong, etc. And massage are associated with improved pain and or improved function and or pain beyond the course of therapy for some of the specific chronic pain conditions that we evaluated. We did have some new evidence on massage therapy, exercise versus acetaminophen, and mindfulness practices. As I mentioned, most of the effect sizes were small. We didn't have a lot of evidence on long-term outcomes, which again is important because chronic pain tends to be chronic. Evidence on harms was limited, but we don't expect to have serious harms, and they were not reported in the trials. The evidence did vary across conditions. As I mentioned, we had more evidence for, say, low back pain than for, say, neck pain or some of the other conditions. There's questions about how much we can extrapolate to all the different pain conditions. We did a series of 3 subsequent updates, quarterly updates leading up to the 2022 CDC guideline, and there were a few studies added, but these did not change the main conclusions, and these updates are also available on the AHRQ website. So I think that's my last slide for the chronic pain, the non-pharmacological treatments report. Should I move on to the plant-based treatments report or take? Yeah.
Yep.
Great. So this is the second review. So this is on plant-based treatments for chronic pain, which I think sometimes people look at that title and aren't really sure what we're talking about. But it's primarily on cannabis. But also the reason why it's not just called cannabis is because we also wanted to look at other treatments for pain derived from plant sources, including things like kratom. So that's why we use a more general term. And, you know, this is an area of a lot of interest. Obviously, I live in a state that I think was the first state to legalize recreational cannabis and one of the first states to legalize medical cannabis back in the day. And it's widely used for many things, including chronic pain. There are perspectives that think that, you know, cannabis use could potentially improve pain, perhaps reduce use of opioids or have other effects. Cannabinoids refers to compounds that are active in cannabis. So just to preface that this is a complicated topic, you'll see as we start getting into all the different cannabis varieties and how to classify them. But the primary active components are THC and CBD. So you'll see us referring to those. Effects of cannabinoids may vary according to the ratio of THC to CBD. So you'll see how we try to address that. We did try to look at kratom. There are other, plant-based treatments, herbal remedies, and things like that. Those weren't a focus of this review. We really addressed, we were really more interested in substances that we think might have beneficial effects, but there was also concerns about potential harms, for example, related to potential for use disorders. And given the interest in this area and that there's emerging evidence, we used a living review approach for this. So this is an ongoing review, and we're doing updates quarterly. Next slide. These were the questions. So benefits of cannabinoids for treatment of chronic pain and harms, and then similar questions for kratom. Next slide. You'll see again, we focused on people with chronic pain. So there has been some use of, in particular, cannabinoids for acute pain, but this is really focusing on chronic pain. We were broad in how we approach cannabinoids. So some cannabinoids are actually synthetic drugs, but we still included them even though technically they're not plant-based. So you can see how the terminology gets a little tricky here. There's lots of different delivery mechanisms. We were broad in terms of, including basically all of them. Kratom was also part of this. These were compared against usual care, placebo, or really any comparator. And then again, the outcomes are similar to what we looked at for the chronic pain reports. Also looking at psychological, outcomes, impacts on opioid use, healthcare utilization, etc. We did not restrict to RCTs here. We also looked at included observational studies with a concurrent control group. Next slide. This is so I was talking about this before, that there's this is complex, that this is not at all like a drug, a single product or drug approved by FDA, where exactly what the components are in the drugs and what the dose is and all this and all that stuff, and it's a single mode of administration. There's many different types of cannabis products. We spent a long time talking to experts in the field, our key informants and technical expert panel, on how we should categorize and approach these products. And we ended up with this categorization scheme. So high THC products, which we defined as products with the THC to CBD ratios of greater than or equal to 2 to 1. There's many different ways these could be derived: synthetic, extracted, or purified. And then you'll see some example products. And just to point out that, about half of the trials of high THC products were in nabilone, which is not approved in the United States. And so this was another challenge that we addressed. Low THC products were defined as those where the ratio was 1 to greater than or equal to 2, so opposite of the above. And then you'll see some examples of those products as well. Comparable THC to CBD product is products that don't meet the above definition, so close to 1 to 1. And the main product that this has been studied in is nabiximols, which is also not approved, or Sativex, which is also not approved in the United States. We also know people take whole plant cannabis products where we often don't know for sure what the THC to CBD ratio is. There may be some information provided, but again, it's messy, and there's a lot of different products. These are things that people, I think you can maybe get these in dispensaries or maybe outside of dispensaries, and then there's other cannabinoids which kind of don't meet the categories above. So, anyways, again, just illustrating the complexity of this area. This is our summary of evidence, and again, there's a lot of evidence here. We tried to summarize succinctly in a table. I think what the key points from this is that the evidence is primarily in the top 2 rows, so that's comparable THC to CBD oral mucosal sprays. So again, nabiximols. There's a pain response that refers to people who experience greater than, say, a 20% improvement in pain. There was a potential effect there, which means a statistically non-significant effect. For pain severity, there was a small effect based on 7 trials, and also a small effect on function. The other area where we had evidence was for high THC products. And these were specifically synthetic high THC products, so dronabinol and nabilone. And most of the evidence was on pain severity, where we see a moderate effect, but no effect on overall function. We really had very little evidence on the other cannabis categories. Part of this was, heterogeneity. The evidence was limited, and when we did have, more than one trial, it was often heterogeneous as well. Next slide, please.
I just wanted to be mindful of time. So just
yeah, I think I only have a couple of slides here. So this is on harms, and just to show that we did look at a variety of harms, and the products where we have data. So again, primarily the comparable THC to CBD spray and the high THC synthetic. There is evidence of harms, primarily things like dizziness, nausea, sedation. Next slide. Just the forest plot. So again, just to illustrate, just to show how we kind of got to some of the results. There's a lot of detail in these forest plots in terms of details of the trials. Next slide. This is for function. The prior slide was for pain. Next slide. And then this is for the high THC products. Next slide. So I just wanted to say a brief word about the living review. So we're entering our 3rd year since the initial review. We've added 5 new RCTs and 3 new observational studies. We've updated analyses as these trials have come in. The main review's findings have remained stable, except the pooled estimate for synthetic high THC to CBD products actually decreased. So some of the newer trials showed smaller benefits. So this is one of the advantages of doing a living review, is you can pick up things like this as new evidence comes in. We did expand the scope to include adolescents and subacute pain, but so far haven't added any trials addressing those areas. And we've discussed expanding the scope to include psilocybin, which I think, it's technically a mushroom, which isn't a plant, but we deferred this given the fact that there doesn't seem to be any trials yet, though some are in progress. And we didn't include spasticity without chronic pain, given that this was viewed as a different condition and there's overlap with other reviews. Next slide. This is just an illustration of how we summarized how we did updates of the evidence. So when there's new evidence, we highlight it in red and whether the and we showed whether the conclusions changed. Next slide. And we have other visual ways to look at this evidence. This is available on the AHRQ website. If you want to go and play with the data, you can look at the studies that each of these point estimates is based on, click on the different outcomes, and this will all pop up there. This is made in Tableau. Next slide. And there's also a report snapshot summarizing the results. Next slide. So to just summarize quickly, comparable THC to CBD ratio plant extracted oral mucosal spray is probably associated with a small improvement in pain severity and may be associated with a small improvement in overall functioning versus placebo in the short term. Synthetic oral high THC to CBD ratio products may be associated with a small improvement in pain severity and response and no effect on overall function. We have limited or insufficient evidence for other cannabis products. There are some increased adverse events, but the studies were not designed to assess serious risks. There's a lot of variability in these products, which makes this difficult. And so far, we don't have any study addressing kratom. So I think that's my final slide. Thanks.
Great. Thank you. Well, that's incredibly rich content. We are over time, but I want to get some voices in for just some initial reactions from our discussants. We do have a chunk of time later that Lucy will be moderating, so keep those questions coming, and we'll also be turning back to our discussants. But let me turn to Nicole first. Any aha moments on these 2 reviews that are just so rich with incredible information?
Yes, well, thank you so much. I think one of the things that came across really strong to me is that we do not have enough therapies out there yet to effectively manage pain. But I think we need to take it a step back. If we know that over 51.6 million individuals live with chronic pain, 17.1 million of those live with high impact pain that impacts their day-to-day life, we have to look at a combination of therapies. Sometimes when we single them out, the one thing we know is that it really takes a multitude of different combination of therapies and treatments and modalities to come together. And if each one decreases pain by 10%, that could be a 40 to 50% decrease and the ability to have a better quality of life. But I found this information just very, very interesting, and I can't wait to discuss it further, just some of the areas that we can work on together.
Thank you, Nicole. Bernard, any initial reactions?
Sure, I'll try to save some time so we catch up. But I think about clinical practice guidelines a lot. It's one of my areas, and this is a great area to really consider that. But it highlights the need for trials and maybe even adaptive clinical trials where we can get to an answer quicker with larger populations. We have 4.5 million people in our own health plan here at UPMC and 40 hospitals, all pretty much with the same electronic health record. So there's a way to collect this data, really work on it, and come up with those clinical practice guidelines. This is a tremendous review and a great project. Interested to see how we can use it, see how it affects cost of care, and all of the rest.
Yeah, fantastic. Yeah, I think that leveraging EHRs and all that for those adaptive trials would be fantastic. Monica, reaction?
Yes, this is fantastic because we need more work on alternative therapies for pain management. And we also know from the research there are persistent disparities in the assessment and management of pain by gender, by race and ethnicity, by insurance status, by income, and by geographic location. So while we're building the evidence around other kinds of interventions that can manage pain, we also need to be responsible and think about ways in which we can make these kinds of therapies accessible and affordable. So one is advocating for insurance coverage of non-pharmacological therapies so that we can increase affordability and accessibility. One of the main challenges that I hear from physicians is that when they talk about other kinds of pain management approaches, if it involves different kinds of classes or other kinds of counseling, it may not often be covered. And so that's a barrier for patients to be able to engage in these kinds of therapies. And the second point is thinking about different kinds of affordability or subsidy programs for patients who might face financial challenges in accessing. And I'll stop there so we can continue on.
Yeah, really critical. Great points, Monica and Bernard and Nicole. So now let's turn to our next set of presentations. We're going to look at the acute treatments for episodic migraine. And I'll turn it over to Zhen and Hassan.
Great. Next slide. So I'm happy to be here. The study was funded by AHRQ, and otherwise none of us have any conflict interest. Continue. So the main report is posted on AHRQ website, and we have a short version journal-style paper, which was published in 2021. If you are interested, you can find the short version. Next slide. So this systematic review, the objective of this systematic review, the meta-analysis, to evaluate the comparative effectiveness of different treatments for acute treatments of episodic migraine. Basically, we have 3 questions, and these 3 questions are separated by 3 types of treatments: opiate therapy, non-opiate pharmacological therapies, and non-pharmacological therapy. Next slide. In this systematic review and meta-analysis, we follow the established methodology of systematic reviews as outlined by AHRQ for comparative effective reviews. Briefly, we include adult patients with episodic migraine. We evaluate the interventions, 3 interventions, as I said: opiate abortive therapy, non-opiate abortive drugs, and non-invasive, non-pharmacologic abortive therapy. The comparisons are placebo and another active treatments as described above. Outcomes are pain, function, satisfaction, quality of life, and adverse events. We captured the outcomes at 4 weeks after treatment. Anything beyond that was not included. Due to the abundance of existing systematic reviews for triptans and the NSAIDs, so we conduct umbrella systematic reviews, which only systematic reviews of triptans and the NSAID were included in the evaluation. For other treatments, we include randomized clinical trials and comparative observational studies. So the initial database search was conducted in July 2020, and we conducted 3 subsequent updates, and the last one was conducted in March 2020. So first one, opiate therapy. So we found 13 randomized clinical trials and 2 comparative observational studies. So opiate therapy compared to placebo, several studies show that opiate therapy was associated with improved pain relief and pain reduction with low stress evidence. For example, with a combination of tramadol and acetaminophen, and the treatment of butorphanol, these treatments were associated with reduced pain at 2 hours and 1 day. But these treatments are also associated with increased risk of adverse events. However, opiate therapy, when it was compared to another active non-opiate drugs, generally speaking, this opiate therapies was associated with the worse outcome with increased adverse events. So, for example, the combination of metoprolol plus hydroxyzine was associated with worse pain relief and functional outcome. And hydromorphine was associated with worse pain relief compared to the combination of diphenhydramine plus prochlorperazine or the treatment of metoclopramide. Next slide. For non-opiate pharmacological therapy, for triptans and NSAIDs, we found 16 existing systematic reviews. And then for other treatments, we have 121 randomized clinical trials and 3 comparative observational studies. Triptans and NSAIDs can be considered as a cornerstone treatments for acute migraine, episodic migraine. We found moderate to high strength evidence that triptans or NSAIDs can improve various pain outcomes compared to placebo. For established treatments, we have dihydrogotamine, the combination of gotamine plus caffeine or antiemetics. These treatments were generally found also effective in reduced pain and improve pain function with moderate or high strength evidence. Before that, sorry, too fast. Yes, and generally speaking, adverse events were minor and transient, and there was no significant difference for these treatments when compared to placebo. For the new treatments, we have CGRP or lasmiditan, and we found moderate to high strength evidence that these new treatments are effective in reducing pain and maintain pain relief or pain freedom. There was no significant difference on AEs for CGRP, but we found the increased number of severe adverse events or some specific adverse events such as gastro adverse events for lasmiditan compared to placebo. Next slide. So for the pharmacological therapy, we found 19 randomized clinical trials and 1 comparative observational studies. There are a lot of different interventions here, and so as a result, only 1 or a few studies for each of the treatments. So we found the low strength evidence or moderate strength evidence that some interventions are effective in improving pain outcomes. These treatments include acupuncture, chamomile oil, external trigeminal nerve stimulation, eye movement desensitization, reprocessing, or remote electrical neuromodulations. Next slide. Conclusion. So there are a number of active treatments, acute treatments for episodic migraine with varying degrees of evidence. And triptans, NSAIDs, antiemetics, dihydrogotamine, CGRP, and lasmiditan associated with the improved pain and functional outcomes. The evidence base for many other interventions are very limited, especially for opiates and for for non-pharmacological treatments. And the slide, next slide. Many interventions, despite we found a large number of RCTs and observation studies, many interventions, there are very few studies available for us, and most of these studies are very small. So we are also unable to evaluate long-term adverse events or intermediate term adverse events due to, as we just limited the short-term outcomes. So next slide. Yes, here's the team who conducted the study, and we especially want to thank our tax audit officer and our KI and the technical expert panel and peer reviewers. Without you, we cannot really complete this work. Thank you.
Wonderful. Thank you very much. So, and thank you for helping us catch up on some of our time, Zhen. That was great. So let's turn again to our discussants for some initial reactions. And then after that, I'm going to hand over the sort of moderating gavel, so to speak, to my colleague Lucy, where we'll get into a broader discussion with all of you, our discussants, our report authors. So again, this issue of acute treatments for migraine. Any reactions? Let's start with Monica.
So one of the reactions that I have, and this is not simply for this group or the studies reviewed, but for the broader field, is that we still need to do much more in making sure there's representation in the research. There's a lack of studies that ensure diverse representation in clinical trials. And particularly when we're thinking about alternative treatments, including cannabis therapies, there's a lot of stigma attached to participating in those trials and those kinds of interventions. So if we increase and improve our equity and inclusion research practices, we can have a better understanding of how generalizable some of these findings are. And that in turn can encourage additional participation so that we can generate greater impact.
That makes a lot of sense. Yeah, absolutely. And I kept throughout all the presentations, it was like, okay, but could you analyze, you know, subgroup effects and heterogeneity and all these issues? But if you don't have the numbers in the trial, that's an issue. Let me turn to Bernard.
Yeah, I just want to highlight what Monica just said. I agree. And I was certainly going to point out, like I did for Dr. Chou's presentation, having more information, better trials, adaptive clinical trials and otherwise would be great. But we have a problem sort of getting to the right kind of answers for the full populations. And we don't do a good job enrolling diverse populations in a lot of these trials. That's why the power of, you know, a lot of data, big data across multiple health systems or certainly large health systems is very helpful. We have a lot of mistrust in a lot of communities with the healthcare system. So enrolling patients from diverse populations is difficult. And that's why community engagement, even from a health system perspective, is really important, not just from where I am in the university a lot of the time. So those are some of the things I think about, you know, relative to getting better information to make better decisions over time. It's a great review. And it's a good way to think about, you know, the opioid crisis too, and different ways to fight it by having this information out there.
Terrific. And Nicole.
I also have to highlight, I think we need more clinical trials, more diversity in clinical trials representation. I thought the information was really robust. I would love it if we started to look more into medical devices as well, and their role in treatments for individuals that live with migraine.
Great, a whole other area. Terrific. Well, I get to now hand over the program to my colleague Lucy, and she's got some questions, but there's also some rich stuff going on in the chat. So over to you, Lucy.
Great, thank you. And thanks to the authors and the discussants. This has been very interesting. I've been taking copious notes myself. But let's start. Most of the questions that we've seen in the chat, Roger, have related to the first report that you talked about. And so one of the questions that really tees off of a point that Nicole made is, you know, what does the evidence suggest about how healthcare providers can effectively integrate multidisciplinary therapies in managing chronic pain? So like sort of a bundle. Did you see any studies in your systematic review that looked at sort of a bundle of multiple therapies?
Yeah, so it's a fantastic question, and it's very difficult to answer. I mean, there's a lot of issues about both kind of sequencing of therapies and which therapies you should use first, and other things like, you know, can you integrate some of these things into, say, primary care or EDs? You know, could you have, you know, I mean, we'd like to have, you know, behavioral therapy or psychology, you know, behavioral interventions integrated into primary care, but you could have physical therapy, you could have all sorts of things integrated into primary care. And then it also raises access and other issues. And, you know, some of these questions, you know, were not really within scope of our review. But I'll also say that they're very difficult to answer. And I don't think that, I mean, you know, knowing this literature, I'll say that there isn't a lot of formal literature looking at, you know, what the best sequencing of therapy is, or the best combinations. You know, we have a little bit of data looking at, you know, say adding exercise to acupuncture and whatnot, which was not a focus of our review. But in general, as Nicole suggested, you often do see some additive benefits. It may not be 1 + 1, but sometimes it's like 1 + 0.5 or something. So you do get some additive benefits. And then I'll just say that, you know, the access and costs and barriers are really critical, both from an equity perspective, but also just how to, you know, manage these patients effectively. I mean, we can't get multidisciplinary rehab in this country. It's not reimbursed. You know, most clinics have difficulty surviving because they can't get paid. And it's an expensive therapy. And this is what the most, you know, challenging, you know, impacted patients would probably benefit from the most. And it's actually very hard to get it. But also even just trying to get something like massage or acupuncture or manipulation, which for some patients, that's their preference. And as we've seen, you know, may have some, you know, benefits, and some people may benefit more than others. In Oregon, they actually tried to reduce these barriers by, you know, the OHA, the Oregon Health Authority, instituted a policy to basically say you don't need to get prior authorizations for all the, you know, we want people to use these therapies and you don't need to get prior authorizations. And theoretically, it, you know, would improve access, but in practice, they did see some uptick in use, but not huge. And I think there's still like tremendous issues. Like, for example, most primary care clinicians have no idea like what acupuncturist to refer somebody to, who's, you know, who's good, who they should be sending somebody to, you know, who's the best physical therapist to manage somebody with difficult, you know, back pain. We just don't have those connections set up. I mean, these are very challenging issues. And I'll just say, as a primary care doc, most of us are operating in a, you know, blind, you know, we're just kind of trying to set up these things without a lot of, you know, structural supports to do it. So even if you remove some of these barriers, like the prior authorization things, there's still tremendous challenges there. So yes, a lot of work needs to be done. I mean, I think our report does highlight that a number of these therapies do seem to be effective, and we think that offering patients choices is a good thing, and then how to put all that together is a big question.
Yeah. You know, one of the things that struck me first of all, I want to share a compliment. I hope you saw it in the chat that people really love the tables that you used in that report and displaying the results. But when I was listening to the report on THC and CBD, and you talked about, you know, the problem in looking at dosages and, you know, the actual compounding of those medications being problematic for the review process. I'm wondering if that's also true for the alternative therapies and the certification of the providers offering those services. Did you see that in the first report as an issue?
It is. So as I said, these are complex interventions, right? And they, you know, so if you think about something like massage, the techniques are tremendously variable. I mean, it can be anything from like foot massage to acupressure to full body, you know, Swedish massage to, you know, all sorts of things. Massage with instruments. I mean, they do a lot of different techniques, all sorts of variability. So it does create, it introduces a tremendous amount of heterogeneity. And I don't know that there's a good way to get around it. I mean, I think treating these like complex interventions and trying to assess, those types of aspects. But for the specific thing you were talking about, the trials often don't give a lot of information about the skill levels or, the experience or training of people who are doing it, or they're just like, top level people, right? They're people from, high level, skilled people who are kind of, and it does raise questions about how applicable the data would be if you just, like I said, if you just send somebody to an acupuncturist in the.
Right. Dr. Roger, did you freeze? There you are.
Sorry.
You're back.
I was saying that like not knowing if you're going to get the same outcomes if you send somebody to, just somebody.
Yeah. I just didn't hear that as a concern or limitation in that first report. And I thought that was something to maybe call out. And I'm wondering, Martha Wetzel, you had 2 questions in here. It looks like Roger answered them, but I didn't know, did you feel like you got answers to your questions? One on the sort of pain reprocessing therapy and the other on the comparisons of, exercise versus non-exercise treatments. Do you want to come on?
Yeah, thank you. Yes, thank you. I really appreciated the answers to both of those questions. I think the exercise piece is especially interesting to me, so I'm both a researcher in this area, and then I am also a patient with chronic migraines. And I think the exercise component here is really interesting to me, along with sort of the discussion about giving patients multiple options, because I think in reality, sometimes what happens is just, you need to go exercise more, and not so much of the nuance gets translated all of the way through into actual clinical practice. So I was kind of wondering if there was a strategy, if Dr. Chou had a strategy of communicating the findings of this report to providers to sort of best communicate that whole spectrum of options and the need to have all of those different possibilities open.
Yeah, again, it's a great question and challenge. I mean, the way I'll just say that clinicians tend to do what's easiest, right? And so if it's easier to just write a prescription, they're going to tend to do that. And so I think that's a big challenge. And then in terms of, thinking about, how to, explain the different treatments that are available and what all the different options are and why there might be a good thing. I mean, I really think, going back to kind of our, biopsychosocial understanding of chronic pain and knowing that there's a lot of different factors that can impact pain, knowing that if people stop moving, that usually will worsen their pain and have a lot of other different, adverse impacts. And so, I really strongly feel that active therapies should be first line. But I also think that, so exercise and kind of CBT type things that, really work at people improving function and getting them moving. But I also think that other therapies are great if people benefit from them and they have, expectations of benefit, they'll probably, experience some benefit. And so, offering people these other options as supplemental to, what I would consider the primary, treatments, i.e. exercise and psychological therapies, I think is really important, but it is very difficult. I'll just say to do that. I mean, exercise, even getting patients exercise, I mean, it's a huge burden, right? I mean, somebody has to take a half day off work if they have kids. I mean, it's a tremendous issue. And that's why I think thinking about, integration into primary care and how we can offer these types of things. I mean, if somebody was in the ED and you could say, I don't think you need opioids or you need an MRI, but I can get you physical therapy today. That's, I think, a much more positive way to manage it than to, give somebody a referral and hope that they can figure out how to get there in a week. You know what I mean? So those are the types of things I think, we could really improve, but they really take a lot of structural changes.
Great. Thank you very much, Roger. And there's a question in the chat that I'm going to let you sort of take on offline so we have time for our other authors about certification of CBD over the counter. But we do have a question for Zhen and Hassan, and I've got some others in the queue here, but I don't know who wants to take this, Zhen or Hassan. Which, if any, of the various interventions have been tested or deemed appropriate for children with frequent migraines?
Interesting. I think the evidence we have is for NSAIDs and triptans as the best available treatments. NSAIDs obviously have been used in children. So I think that's probably what most people start with, but people do use triptans as well in children.
Have many of the studies been done on pediatric populations for these treatments? Or are they still limited?
I think our review focused on adults.
Okay.
Yeah.
Great, thank you.
Triptans are used in children.
And, considering the varying degrees of evidence for acute treatments, how can healthcare providers navigate the decision-making process to select the most effective intervention for episodic migraine management in adults?
Yeah, so I'll answer this question also. So the choice, obviously, we always say the choice should depend on the patient context, right? So if we look at the available treatment, so if someone has an acute onset migraine attack that you want to treat quickly, say something that happens when they wake up from sleep, then there is the sumatriptan that can be given as an injectable or as a nasal spray. If someone's characteristics of the pain is more long-lasting, then there are triptans that are more long-lasting, such as naratriptan. If someone has cardiovascular risk factors or has a history of a heart attack, then they cannot go the triptan route, and perhaps even NSAIDs are not very appropriate there because they may increase the risk of this cardiovascular event. So in these patients, we may go the route of the newer medications, which are not vasogenic. They do not cause spasm in the coronary arteries. So I think we are, particularly in the migraine, compared to what Roger presented, we are lucky that there are a lot of different options. And you just need to base the decision based on the characteristics of the pain and the patient. If someone has a lot of nausea and vomiting, for example, we've demonstrated in this review that some of the antiemetics are very effective as well.
Good point. Thank you. And one final question before we move on to the next section. Given sort of the limited evidence base on, some of these interventions that we've talked about, what steps should be taken to expand the research landscape? Where would you sort of point, researchers to sort of fill the gaps necessary to advance the field?
So this actually ties very, very nicely with some of the work that we've done with AHRQ to follow up on these specific reviews, actually. So we've, in this review, we found very little evidence about treating migraine in pregnant women. So as a follow-up to that, we extended our approach to query our health system data. And we've done what we call an emulated clinical trial, which is essentially a study that derives its data from the existing electronic medical record. And we looked at patients in multiple states that belong to the same health system. And we looked at pregnant women who use triptans to see if there are any adverse events or any complications that happen with the use of triptans. So that's one way to advance the evidence base, is to take these systematic reviews, look what evidence gaps have been demonstrated, and follow that through perhaps looking at health systems data and emulating trials, or doing trials, regular trials as well.
Yeah, the real world data has a lot of promise. So thank you for that. We're just at time now, and I see Jeannie Dalton has sort of chatted in that AHRQ has ongoing review funded by PCORI around behavioral interventions for migraine prevention, which is noteworthy as well. And I know we've been very short on time. Thank you very much to the authors for joining us in this discussion. Thanks to the audience for the questions. Lisa, I'm going to turn it back to you for the next area on the agenda.
Terrific. Thank you very much. So now we get to dig a little deeper with our discussants and all of you who are listening on the dimensions of, and these have already come up both in your questions and in the comments, the dimensions around policy that drives appropriate, evidence-based therapies for these various conditions that we've been focused on today, the equity issues that have already arisen, and then some of the issues for health systems. So, and I have some questions for our discussants, and also please put additional questions in the chat. It looks like we've already gotten an answer. There was a policy question that came up around certifying body, and Roger answered Mary on that. But there was also a question earlier in the chat from as a reporter, and I'm trying to get myself back up to that section. Yes, a reporter, Ben Adlin at Marijuana Moment, and you're curious about the Schedule I status of cannabis, how it's affected this research, which kind of also gets to the standardization. So maybe if I don't know if any of our discussants want to take that one on, or a report author, before we dig into some of the other policy dimensions.
Yeah, I responded in the chat, but at least in the United States, the cannabis scheduling has made it difficult for federal funding, but also makes it difficult for, say, drug companies to get funding, at least historically. I think that's getting better now. But this is why, like I mentioned in the presentation, many of the trials have been done in other countries on products that are not available in the United States. And this, this creates a lot of, questions about applicability, especially if people are trying to apply this stuff to, the findings to like things that they're getting at their local dispensary, which, probably is not pharmaceutical grade, whether the amount that's in there actually correlates with the actual, there's all sorts of issues there. So it creates a lot of challenges. This is a really difficult area to study. People, people have tried to study, just kind of use of, non-pharmaceutical grade cannabis, which is probably how most people are using cannabis, right? Most people are not getting a pharmaceutical product. They are, getting something from the store, from the shop, or from, another source. And it's actually very difficult to measure what they're doing. How much is a cigarette, a joint versus, take an ingested and all this stuff. How do you actually calculate that? It's very difficult. So and these methods are starting to evolve, but I still think that there's, room to improve there.
Right. Thank you, Roger. So I'd like to turn to Nicole with another question, which is, given what we've heard today about the limited evidence on the long-term effectiveness of treatments for chronic pain conditions, from the Pain Foundation and what you hear from your patient communities, what kind of policy measures could be implemented to guide the management of chronic pain over extended periods that balances, maximizing functionality and patient outcomes and safety, while addressing the limitations of the existing treatments? So what other issues or advocacy have you been involved with for that issue of long-term effectiveness?
Yes, I will definitely answer that, but I wanted to add just to what Dr. Chou just said, because I think he brought up such a great point. And as an example, I think when we're talking about safety around cannabis-based therapies, I would like to use an example just around CBD. And safety is such a big thing right now. More than 45 million Americans are utilizing CBD, yet only 16% of those labels are accurate as to what you are getting. And so until we start addressing those issues and looking into regulation, the 2018 Farm Bill made CBD legal and available in all 50 states, but there aren't any guardrails right now around third-party independent testing and making sure that accurate labels are there. And so currently that is another area that US Pain is really advocating for. And there is actually legislation at Congress right now with the FDA to make CBD a dietary supplement, which would therefore ensure these guardrails so that labels are accurate, there is testing being done, and that those living with chronic pain know that the products they are getting are safe. And so I did want to just add that in because I think it's so important. But then back to your other
initiative. Yes, go ahead.
Yes, but then around your other question, I always like to say, if you meet somebody with pain, you've met one person with pain. It is so individualized, and we really need to look at that whole person and the individual that is coming to you. If you are a provider, meeting them where they are, listening to what they say, and making sure that it is a positive patient-provider relationship where both sides are putting in the time and input to educate one another and to learn about different things that are occurring. CMS earlier this year actually introduced new chronic pain management codes for physicians and nurse practitioners who treat people with pain, and they can use these monthly to work with patients to really develop and revise a multidisciplinary plan for that person. And so these codes really encourage a comprehensive approach to pain management, a long-term relationship between the patient and provider, which unfortunately is very fractured. And so hopefully we can reestablish that and make it stronger. And that these codes are allowing practitioners to be reimbursed for comprehensive care. And I think that this is so important when we are looking at how can we help manage pain? How can we find modalities that will ensure that somebody has the best health outcomes that they can and improve quality of life? The other thing that I think is really important is the role of support groups, and especially looking at peer-led groups. US Pain hosts over 60 online free peer support groups every single month. And for us, it really is about teaching skills for managing life with chronic pain. It is for individuals to come together in a safe place and they can share what has worked for them. They can learn skills such as pacing, activity modification, all these different things. And we have just noticed a huge difference in sort of improved quality of life and function amongst those that are attending our groups. And I think it would be really fascinating and very beneficial if there were more studies done around peer groups and the role that they play and the positive role that they play in individuals' lives, and finding ways that there could be more government grants and funding to support these programs would be very great as well.
Oh, terrific. Great. And your point about, really that it's echoed by Cindy in the chat about, I mean, we're as patients with chronic pain are conducting sort of N of 1 trials. What is the combination of therapeutics and interventions and lifestyle modifications that work for them in their context, again, because of that biopsychosocial influences. So thanks. I want to turn to another question here, which is shifting to the migraine report, which is how can policies promote more shared decision-making between, again, providers and patients? And be mindful of what Roger said, and we know this, a former PCP myself, doctors just write scripts. You're busy, you've got your RBRVSs to meet, whatever. But how can we promote shared decision-making with patients so that those who are experiencing migraines are really well-informed and can actively participate in choosing the most suitable treatment based on their preferences and medical needs? Any thoughts on that?
I'm actually going to go back to the CMS codes because one of the requirements is actually pain and health literacy counseling. And so again, if we utilize CMS codes, you have more time to talk to your patient and really make them more educated, not only around migraine disease or the disease that they're living with, but also those treatments that are out there. And together, as a patient-provider relationship, you can devise an individualized plan that will work for that individual person. Unfortunately, though, we do always have to look at access issues, and that has become a big struggle in the migraine community, as well as chronic pain and other diseases.
And do you have any data, Nicole, on the uptake of those codes by providers? Is there, I mean, does Medicare report on that? Like how much do PCPs actually know they can use these new codes?
That is actually such a great question. I do not have the exact information, but I could get back to you on it. They were instituted in January of this year.
And I wonder on that point whether Bernard, from a health system perspective, might weigh in on that question as well, because obviously all the documentation that happens in health systems as more and more PCPs are now employed in health systems. Any comments on that about the use of those new codes and how that can help promote shared decision making?
Yeah, I have a couple thoughts about that, and it relates to something Roger said a while back ago about this, idea behind teams taking care of patients and interprofessional activity and work. My other hat is a cleft and craniofacial surgeon, and we're sort of the model in that space for team care and have been for over 50 years. You don't see it a lot in healthcare, and it's because of something Roger mentioned and relates to those codes. If you bill for a service and 3 other providers see that patient that same day, they can't bill for those services. The claims get kicked out. And there's not policy and or procedure around getting that effectively done. So there's no incentive for teams to form because they can't really stay viable. But it's one of the very best ways to have interprofessional dialogue and really get to clinical practice guidelines that make sense with a fully informed group of individuals, helping that patient get to the quickest and best response to their pain possible. So when I think about what Nicole said about individualized pain, my best way of thinking about dealing with that is getting a group of people that come at it from different angles, can all talk at the same time about how to deal with that, and then get it done. And in a place like ours, like UPMC, Lucy's here too, she understands this. It's a massive system. You can leverage the health provider network and the individualized care therapy across multiple domains, urban domains, rural locations. You can spread this type of care out. You can use telehealth, but we have to have a way to be able to do that and bring those individuals together. So I think policy around funding teams, bringing the power and capability of an integrated healthcare delivery and finance system like ours to do that, or others like Kaiser or Northwell, other large systems that can do that. That's one way to sort of tackle that set of issues and try to get to those answers. Also study them and get better data along the way too.
Yeah. Great points. You brought up something that I wasn't going to ask folks about to comment, but I'd love to sort of throw this out to both our discussants and authors, which is the role of telehealth in pain management. Because that's a whole new world, and with the issues around cannabis, I can't even, my head can't go there. But comments about how effective are we able to leverage telehealth, particularly for rural populations and adequate pain management? No takers?
I can go ahead and get started. I think the expansion of telehealth services is really critical because it can also be established in partnership with community-based clinics that offer a wider range of pain management options. And this can increase accessibility. This is particularly relevant for patients in rural settings where they might be healthcare deserts. And the alternative structural barrier that accompanies that is that many rural places also lack broadband or Wi-Fi. I know the Biden administration has committed to providing universal broadband by 2020. But right now, the very modality with which we can reach those hard to reach populations are currently unavailable. And so we also need to think about what are the ways in which we can make sure that there are equitable distribution of Wi-Fi and broadband so that we can employ telehealth to its maximal capacity.
Great, thank you.
Yeah, I'll follow up on that. In rural areas, the migraine and chronic pain is managed by primary care, and people may have to drive 100 miles or 200 miles or 300 miles just to get to a specialist. And I think specialist care will be quite helpful in chronic and acute pain. So access to a migraine specialist and neurologist, access to a pain specialist will if that can be provided and reimbursed for virtually, I think that will clearly improve the quality of care for people with pain.
I also would agree with that. People that are living with high impact chronic pain, most of them cannot drive. So they are therefore relying on a care partner, care provider to help them get to that doctor's office, which means that they are now missing work. In a recent study that we did last year, telehealth is something that our community wants to see continue on because it is actually allowing them to get access to care and treatments that they need. Much more needs to be done, to Monica's point, to make sure that everybody has the ability to utilize telehealth. But it is something that we at US Pain Foundation are continuing to advocate for, to make sure that individuals have this so that they can reach out to the providers that they need and get the care that will hopefully help them along their journeys.
Yeah, and I know that telehealth is an area where AHRQ has been active with other reports and initiatives as well. I heard a voice trying to jump in. Is that you, Bernard?
Yeah, sorry, it's Roger. And
Roger.
We've done some of the reports for AHRQ on telehealth, but I was just going to say that, COVID changed a lot, but, the old, and this talk is not about, this session is not about opioids, but the old way of managing chronic pain was to make somebody come in every month, and sometimes more frequently than that, every week or two, to get a prescription, which is not very patient-centered, especially for people who are, traveling long distances. I mean, in Portland, we had people coming from Southern Oregon, every month, which is a 4 or 5 hour drive each way. So I think there has been progress made here, and there are more flexibilities in terms of prescribing controlled substances. I think for chronic pain with the non-pharmacological treatments, one of the challenges is, which ones can you deliver effectively by telehealth? I mean, psychological therapies, we probably can do that, through telehealth. Probably exercise with a physical therapist or something like that. But some of these therapies you can't do massage, or
Exactly.
something like, or acupuncture. So it really varies depending on the type of intervention. So anyways, but I do think that again, thinking from a patient-centric way, that telemedicine is very important, and there are other models of care where it's become the norm, like for management of long COVID, right? Telemedicine is kind of normal. So anyway, but it has not been for chronic pain.
Right. I want to turn to some of the questions that are coming in the chat. Oh, but Nicole wanted to weigh in, and then I'll get to Cindy's question.
One of the things that I just wanted to add on that, as an organization, every single month, we host a session called Building Your Toolbox, and we bring in a provider or practitioner to teach a self-management strategy or skill. And so it could be something as mindfulness, or it could be acupuncture or acupressure points, and things that people can utilize from their home to also help them. And so yeah, I know it's not enough, but it's a start to find things that individuals can do from the confines of their home that will also bring together this multidisciplinary approach.
Terrific. Great. So Cindy had a question about what are private payers doing to promote team-based care and comprehensive pain management, with the aside that, yes, they seem to pay for surgery, which is obviously a high ticket item. But this other kind of care might actually be cheaper with better patient outcomes. So I don't know, Bernard, do you want to comment on this? Yes, from a health system perspective.
Yeah, I do. I don't know that there's a lot being done, but I certainly wouldn't blame the private payers for that, or other types of payers. It's really a problem of the system of the drivers in healthcare in the United States. So you're singing my song. It's exactly what I would love to see happen, is for this shift to occur so that team-based care doesn't have this hurdle of just producing more widgets, gets the healthcare providers paid more. It makes much more sense to do something like this in a team fashion, as it does for oncology or lots of other areas that benefit from multidisciplinary input. So I would love to see that. And it's not just sort of a policy, wave the wand type moment, but it's certainly a discussion in that space as well as with the payers.
Yeah. And do you have any sense, Bernard, or Lucy, about whether ACOs are any better at managing pain and doing this more comprehensively than than the widget-based payment systems?
Well, I'll jump in before Lucy, but I think, we're not there yet for the total risk model, but that's one way that you could do this. If you had a total risk model with a population to take care of, it is an incentive to do it via team-based care. We would save a lot of money. We've seen that with back issues and management of complex back issues, including pain. So we would do well to use that model. Lucy, what do you think?
Perfectly put. I agree completely.
Right. All right. Next, we have a question here about whether there are studies looking at, and we've been talking a lot about self-management approaches, Nicole, and others, but studies that look at that self-management for pain, chronic pain. And Anjali, do you want to just go off mute and so I don't have to just read your question? You can just vocalize it.
Sure, I can do that. Thank you. Yeah, I mean, part of my interest in exercise and some of these other approaches has to do with, like, I don't feel like we're really tapping into the power and the abilities of the patient and also the control it gives them over pain. And, there's a huge industry, self-care, or if you want to call it that, or optimization, where people are really doing all kinds of stuff outside of healthcare. And I just feel like if we had a more combined approach where we were actually able to, serve as, resources, but also help patients take advantage of what they can do themselves, which I do think is part of the appeal of things like exercise, massage, peer support, also some of the availability of cannabis, and sure to come psilocybins, et cetera, right?
Yeah, it really speaks to the issue of patient agency and control over their condition.
And I think sometimes we don't study these things because they're hard to study, but they actually would provide a huge amount of access if we were able to.
Thoughts or reactions while folks are thinking? I would just comment that as we've talked about research, clearly it's already come up multiple times. We need more clinical trials or adaptive trials, and we need more diversity in those studies. But I think since this is so much something that's dependent on patient-reported outcomes and patient voice and patient engagement, that bringing together mixed methods with qualitative research and ways of collecting that lived experience of the individual patients, and I would add, and their care partners, caregivers. I've been working with the VA on a clinical council, or not with the VA, with the Elizabeth Dole Foundation, and they focus on the hidden heroes, who are the caregivers to the veterans with chronic conditions after their service. And so we really have to think of them as well as part of the team-based care that Bernard speaks so eloquently about. So any thoughts on this thread around this self-management and what additional studies we need?
I mean, I'll just say that I think self-management is important. In the 2007 ACP low back pain guideline, which I led, that was the first recommendation on treatments, is that everybody should be counseled, try to remain active to the extent you can, and then self-management practices, education about, natural history and things like that. It is difficult to study. Several people have asked about peer-to-peer support groups, and I don't think that's been studied a lot, at least in RCTs for chronic pain. I think a lot of that comes from the addiction literature, where that has been looked at more, and maybe HIV care and things like that. But at least in chronic pain, I'm not aware of a ton of literature on the effectiveness of peer-to-peer support. There used to be these back schools, which were kind of like that. They would be these group sessions where you would do a variety of educational things and some exercises and some other things, but it's in a group setting. But that was a very kind of Scandinavian model, and was not widely taken up in the United States and kind of disappeared. And I would say you can't really get that kind of back school kind of stuff anymore. But there are studies that actually show that if you give somebody a $1 booklet on self-care for their back pain, that's about as good as going to see, get formal exercise therapy. So it can be quite effective, but I think it's hard for clinicians to kind of believe that it's effective or take learn how to deliver these interventions well. I think, sometimes maybe patients perceive that they're not getting anything if it's just, if their physician is saying, read this book. And so you have to be skilled at doing that. You have to do it in a way that's empathetic and is not minimizing the patient's symptoms. And it's not easy. It's not just, taking stuff from, studies and just, being able to do it automatically. It's really understanding how to interact with people in effective ways.
Roger, I'm so glad you brought up these issues because it brings up the whole issue of it's one thing to know what is effective based on an RCT. It's another thing to deliver that adapted to the particular patient and system and context issues. And that's where implementation research really comes in. And the NIH, for those of you who don't know, sponsor a lot of implementation research across all the institutes. And in fact, the annual conference on that is happening in 10 days in Washington. We're co-hosting, full disclosure. But again, it really speaks to the importance of not just straight efficacy or effectiveness trials, but also studies that are hybrid and get at implementation issues, because it is so dependent on clinician capabilities, system capabilities, and then patient capabilities. I want to get Monica involved here. I want to talk a little bit more. You brought up the issues of telehealth to try to address some of the disparities, but what else, what other strategies or policies can be implemented to ensure that the benefits and the risks, you want to present both of those, of these therapies are distributed across diverse communities, and particularly those who have been historically underserved or marginalized or excluded from healthcare access to high quality care?
Sure. I have a couple of strategies, and I'm putting in a chat a link to a health equity commentary that I published a few months ago on this issue. I think one that is within the healthcare sector's control is cultural competence and education. We know that the assessment of pain varies, and not all providers necessarily use the same types of validated instruments, and not all instruments have been validated across different populations based on ethnicity or race or culture or language or other factors that impact their identity. And people emote and express pain in different ways. So sometimes a nurse provider might say, I won't consider X treatment unless the pain is 7 or above. But a 7 means different things to different people. And so in assessing pain, which is the first point of effectively managing it, we have to be able to comprehensively assess it and make sure it's culturally competent and appropriate. And that means getting at the multiple dimensions of pain, not just the physical, but the emotional, the social, and the other aspects that impact the patient's life, while understanding that there's going to be some level of pain that will be expected. So it's not realistic to get to a 0. So part of that is making sure that the assessments are standardized and comprehensive. And the second approach is community engagement and outreach. And that involves inviting patients into the discussion so that there can be shared decision making. And oftentimes patients aren't always, they're put in a very vulnerable situation, and it might not be a topic that they feel comfortable talking about. And so having community-based health programs and partners, as well as inviting family members or other caregivers or other support partners to the conversation, can be really essential. And then finally, I'll end with accessible healthcare services. I think there needs to be further support in the development of community health clinics that offer a range of pain management options. And then making sure that when we are testing them, whether through pragmatic trials that involve a combination of implementation science and traditional RCTs, that we are inviting and targeting representation in research. And so this includes participants and patients that have been traditionally excluded, as well as experience greater disparities in pain management. So these include patients of color, women, patients across all age ranges, and also children and adolescents who are very limited in advocating for themselves and expressing their pain.
Yeah, thank you, Monica. I want to get other folks on our discussion to weigh in on this issue of what else we can do for disparities. But I wanted to ask a quick question, which is we've seen a real growth in the focus on the use of community health workers of various kinds and doulas in helping extend that sort of healthcare team, birth doulas, other death doulas. Is there any role or exploration of the role of the community health worker in pain management potentially? Because again, these are chronic local issues. No, Roger, nobody's studying any of these. Bernard.
Sure, I'll take it. I think that's a systems issue too. I mean, we have to use everything at our disposal to try to get this geographically distributed network of pain management services to the people that need it. And to Monica's point, that sort of centers on trust in healthcare and having community engagement there. Not all communities are necessarily going to warm up to someone who looks exactly like me in every moment as a physician in a clinic in an urban-based center. So any opportunity from any type of healthcare provider that has the chance to start that conversation and bring them into maybe a team-based care would be great, whether that's a doula, a PA, a nurse practitioner, anybody in this space. I think it's a really important way to both get that geographic distribution and also tailor the resources to the community that needs it the right way, not just a singular way.
Great. Bernard, since you have the mic, do you want to say anything else about disparities and strategies building on what Monica's covered?
Yeah, I agree with the telehealth options, virtual care options. I think those are big. They were really helpful for us in community-based care during COVID. And, what's helpful about that is we can get specialty care to those individuals in rural areas that can't drive that 5 hours that Roger mentioned, I believe. We have that certainly as an issue in Pennsylvania, even with this network of hospitals all over the place. Specialized care, whether it's for migraines or anything else, is hard to get. And someone in the chat mentioned the exodus in healthcare and that issue. This is a way to really distribute that very specialized care to the right individuals at the right time. We just need to really leverage it the right way.
Great. Nicole, did you want to weigh in on the access, equity, and disparities dimension of other ways to advance that? And then I want to turn to some of the comments in the chat.
Yes, well, I just want to echo the sentiments of Monica. One thing in the migraine community that we do is this is our clapping. And I was doing that under the table as you were talking because I could not agree more with what you were saying. A couple of things that I think are really just important to address is making sure that we, and I see Bernard figured out how to do it on there. That works too. Is making sure that we can continue to provide education and support to individuals where they are, and making sure that those that have been marginalized, underserved, excluded have a seat at the table. And so that is something that US Pain really does strive to do. We have specialized peer-led support groups. And again, all of our peer groups are led by people that have gone through comprehensive training, but they are also volunteers. So we do have a BIPOC group. We have an LGBTQ+ group. We have a flagship program that's a print and online publication, and we've done 3 editions looking at healthcare disparities, really trying to start a new conversation and to make people aware of how people have been discriminated against and marginalized for so long, and what can we do to make sure that we have equitable access to care for every single person. And I also wanted to say that I was so glad, Monica, you also brought up teens and youth, because that is another underserved population that there is not enough out there. And these poor children and their families are scrambling for anything to help their children not have pain. And we need to do more research in that area as well.
Great point. So Roger kind of weighed in on Lucy's question about workers' comp and the role of employers, but I'd like to maybe get a few more voices thinking about that, because yes, obviously a lot of injuries in some industries stem from work-related injuries. So Lucy, do you want to expand on your question?
Well, I don't really have a lot to expand other than saying it seems to me if you're looking for various levers and places where we could do some of this research, and whether or not workman's comp as another insurance mechanism is covering some of these alternative therapies. I think that's really where it weighs in, and I'd defer to Roger to really weigh in and what he's seen in the literature on this.
Yeah, especially in Scandinavia, that was pretty
Yeah,
interesting.
that was very interesting.
Yeah.
Yeah,
Roger.
I mean, that's what I was talking about. In Scandinavia, they used to have systems, and they may still have systems in place where if somebody, you know, has a back injury, they immediately are referred to, you know, rehab and some of these programs. I mean, it's like automatic. And some of the interventions that I was talking about earlier, like multidisciplinary rehab and related things like functional restoration and work hardening, these were all developed from workman's comp, you know, in workman's comp settings. I think the one issue to bear in mind is that the goals of patients and employers and workman's comp aren't always the same. And so you have to kind of keep that in mind. And, you know, as a clinician, you know, you sometimes get stuck in the middle where workman's comp is saying this person should be able to work, and the patient is like, I can't work. I'm in too much pain. But yes, I think, you know, if you can get people to look at the long view, I think that a lot of the perspectives and goals would be the same. But, you know, I think too often it's like, you know, we need to get this person back to work, and they're not thinking about kind of how, you know, what, you know, how the person's going to be in 3 or 5 years, which is really what, you know, would be most beneficial all around. So I think these are the kinds of things to just bear in mind. Yeah.
Yeah. So we just have a few more minutes left. So I want to both encourage our audience to throw in their question or comment before the end. But I want to turn to our discussants and report authors, it kind of with a general open question about, you know, what's another point you want to make sure this audience hears, not just the folks who are the over 100 folks who joined us live today, but they will have this recorded. What have we not gotten to that you really want to get out there or underscore as we think about the future of pain, non-pharmacological managements for pain?
I mean, I don't know that I have, I mean, I've talked a lot, so I don't know that I have something super specific, but you know, the issue of stigma hasn't really come up, and I think it's very difficult to study, but
yeah,
the way the, you know, healthcare has been structured, you know, it's like, you know, remember we were talking about, you make somebody come in to, you know, all these visits, you know, to get all their psychological therapy and their exercise, to get their opioid, their stuff, and then you stigmatize them because they aren't able to work. It's like, who can work if they have to be, you know, attending, you know, visits every, you know, miss work every, you know, week or two. And so I think the treatment has been, you know, not fair. And a lot of it has been related to, you know, things that are structural, and, you know, and we really have to rethink, you know, how to effectively deliver care. Right. And again, COVID changed a lot, but we still have a lot more to go in terms of, you know, can we effectively manage chronic pain in ways that are really, you know, different from the old model of, you know, making somebody come in every month, sending them to 5 different you know, specialists, and, you know, 15 different visits, and that's not going to work. It's not efficient. It doesn't, you know, help the patient, and it and it's going to make them unable to function because they can't, if they're that busy just trying to manage their pain, they can't, do the other things they need to do to have a life. So anyways, I think the stigma thing is important. And, some groups, NASCM has produced like these, patient journey maps and things like that to try to help patients kind of navigate some of these things. So anyways, but a lot of this is kind of beyond research. It's like, it's not something that, I can look at very easily in a systematic review. It's how to apply this stuff and effectively implement it.
Yeah, and great. Thank you so much for raising the point about stigma, which clearly differentially affects different populations and subgroups. Nicole, do you want to jump in on any topic, this or another?
Well, yes, I think individuals that are living with chronic pain are highly stigmatized. And so I'm thankful to you, Roger, for bringing up that point. There is so much that we need to do to help support the 51.6 million Americans that are living with chronic pain. I think the point that I would like to drive home as a patient advocacy organization is that we are here for those individuals that live with chronic pain. So if you are a practitioner or a provider, please go to our website and use us as a resource for your patients to help them find peer-led support, to help them find education and information, to connect them with advocacy opportunities, so that we can fill in the gaps when they aren't able to come and see you. It's uspainfoundation.org, but I really appreciate being here today, and multidisciplinary care is something that is so near and dear to our organization's mission, and we would love to collaborate and work alongside anyone here or watching later.
Yeah. And let me turn to Bernard in terms of what are some incentives, changes, what else can health systems do, or what should policy do to help health systems do the right thing?
Thank you, Lisa. I want to thank you for letting me be a part of this. Just to reemphasize what Nicole has been talking about this whole time, and Monica's also been talking about, that ties into my interests. I think we really need to leverage the big data opportunity that health systems have, particularly large health systems and payers have, whether that's Optum, Blue Cross Blue Shield, or others. Establishing comprehensive data collection systems, utilizing digital platforms to collect real-time patient-based data, registries that are NIH or other agency funded that can do this, and allow us to look at safety and efficacy of these strategies, and encouraging research collaborations to fill the evidence gaps that we have. We obviously highlighted a lot of those today, despite the good work and the great reporting that's been done that we heard about earlier. I think that's the real opportunity from a systems standpoint, is to leverage that large data set.
So Bernard, if I could sort of do a little sort of adjacent question, which is, it hasn't come up, and this will just reflect my lack of knowledge of the pain sector, but we do hospitals, health systems, Medicare, gold stars, all these ratings that the organizations in healthcare get. Do they get rated on their pain management, on any dimension of their pain related care? And if not, why not? And is that an incentive, a strategy? Trying to think of ways to elevate these issues.
Yeah, I can see Nicole fidgeting already. That's a whole nother session to talk about. There's a little bit of a backlash because, smiley faces and frowny faces and the opioid crisis have kind of said like, oh, wait a minute.
Vital sign that.
Yeah, exactly. But we still have to measure it. We still need to look at it. We still need to look at social determinants of health in these spaces, like Monica's been saying. So no, to my knowledge, we don't really have good yardsticks, or more importantly, kudos to systems that are sort of doing it right. This is an exemplar. Please do it like this.
Nicole, did you want to comment?
No, I think I'm good right now. I know the time is short, but I do think that could be a whole other conversation, and I would love to be a part of that.
Great. All right. And I want to make sure if Monica, we sort of riffed off your comments around disparities, but if there are other comments that you want to make, you get another couple minutes before I turn it back to Lucy to wrap us up here.
Sure. I'll just say this is more for all of us to have better understanding of the context in which different kinds of therapies are recommended. And so there's stigma associated with pain, and there's also stigma associated with different kinds of pain interventions. And I'll use the example of cannabis. So BIPOC communities have had disproportionate criminal legalization issues related to the use of cannabis, and that might influence their willingness to discuss cannabis therapies with healthcare providers. And so keeping in mind the broader context of the world in which we live in, and so many other sectors intersect and influence health. So transportation, housing, employment, education, the criminal justice system, and thinking about all of these ways in which people have lived their lives and have their lived experiences can really impact the way we do the research and the practice implications that we have for improving equity in pain management. And it involves a multifaceted, multi-sectoral approach. It can't be done with just healthcare alone, but in collaboration with communities, with patients, and with policymakers, I think we can improve the way forward. And really thankful to be a part of this discussion and learn so much from all of our colleagues, including Bernard and our discussants. So thank you.
Thank you. So before I turn it over to Lucy, the last folks I want to call on, Hassan or Zhen, any final comments from you? Roger, like you said, we've heard from you, so I think we've got most of what you want to say, but yeah, you also can jump in. But Hassan or Zhen?
Just a final comment, particularly with migraine, I think the two things that probably would help, number one, will be decision aids or shared decision-making tools, because we have so many options. So it's different from what Roger presented. He presented a lot of challenges, but in terms of migraine, I think we have a lot of treatments. So that might be a challenge, having too many treatments. So this shared decision-making tools, I think, will be good, will help clinicians and patients reach a common ground and choose the best treatment. And then reimbursement issues, because some of the newer medications for migraine are quite expensive.
Great point. All right. Well, I think I'm going to turn it back over to Lucy to wrap us up here. It's just been a pleasure being part of this conversation. Lucy?
Thank you, Lisa. And thank you, everybody, for joining in. Thanks to our participants for their great questions, to the authors for sharing their work, Roger, Zhen, and Hassan, and our discussants. Very rich discussion, Bernard, Monica, and Nicole, and as well for the support from the AHRQ staff and the Scientific Resource Center in making this possible. A reminder that for those of you who want continuing education credit, the link will be posted in the chat. I think it just popped up. And we will be making the slides and the recording available for distribution. This has just been phenomenal. Thank you, everybody. Have a wonderful day. We appreciate your time and attention.